Okay, you can start.
All right. Macrocytic megaloblastic anemia should be followed with the determination of vitamin B6. Vitamin B6 pyridoxine normally causes one of the microcytic microchromic anemias, the sideroblastic type of anemia. Pyridoxine phosphate, it's one of the derivatives of vitamin B6. Micronutrients, it's a general name. Niacin is not does not fall in any of this. Then vitamin B12. We know that the causes of megaloblastic anemia is either B12 deficiency or folate deficiency. Yeah? Um, and you know macrocytic anemia can be divided into megaloblastic and non-megaloblastic. It's not the right place to discuss, but I know you've already talked about it in the sports, and how you can be able to differentiate the two, especially if you're given slides, because megaloblastic anemia will have these ovalocytes, while the other one, they say they don't have ovalocytes. And then a key thing is also the polymorphonuclear cells, like the neutrophils, are going to have hypersegmented nuclei. Yeah. So if you see a cell that has so many segments of the nuclei, normally the 3 to 5 for the neutrophils, you will be able to know that this one is the megaloblastic. So megaloblastic will have those features, non-megaloblastic won't have those features. You should also know what are the causes of non-megaloblastic, including liver diseases and also alcoholism, among others, which you can check out. You can move on. Right. Most erythropoietin is produced in by, if I'm not sure if there's any other side that produces it, but all I know is that kidney is the major source of production of erythropoietin. And that's why when you're having a kidney failure, especially a chronic kidney failure, when you talk about it in clinical chemistry, one of the signs of a chronic kidney failure is that you're going to have an anemia. And that anemia is going to be a normoblastic normochromic anemia. And the source is going to be you're not producing red blood cells because you're not having erythropoietin. So the answer there is going to be the kidney. All right. Defect in factor 10, I will show in. So we know that we have three pathways when you're having the coagulation systems. We're having the extrinsic, the intrinsic, and then we have the common pathway. So the extrinsic, what happens is that you want maybe you need to get injured. So it's something extrinsic out of your body that is causing the coagulation. For the intrinsic one, you want something within your blood vessels. You'll need a surface. And that's why when you talk about the factors that are going to be at the topmost in intrinsic pathway, they're normally called surface dependent factors. Yeah, in that they'll require a surface for them to be able to start. So for the extrinsic, when you get hurt, you're going to expose your tissue to the atmosphere. And that's where your factor 3, the tissue factor, comes in, activating factor 7. And then factor 7, it's very easy to know it's 3 plus 7 is going to get you into the common pathway, which is factor 10. Yeah. So 3, 7 will get you to factor 10. So that's the extrinsic pathway. For the intrinsic pathway, however, you'll be able to require something to be able to cause an activation. Yeah. So sometimes they normally are referred to the ki, kin, ki, kininogens, the high molecular kininogens, but I don't want to get into that. And the first one is going to be factor 12. Yeah. So when factor 12 is activated, you want to activate factor 11. When factor 11 is going to be activated, next one is not going to be factor 10. We throw factor 10. So you bring the next one, which is 9. So it's 12, 11, then 9. We remove 10. 12, 11, 12, 12, 11, then 9. Then in presence of factor 8, they go to activate factor 10. So 10 is like in the middle where the intrinsic and extrinsic will come. And that's where your common pathway will start. Factor 10 in presence of factor 5 will be able to give you, will help you to activate factor 2, which is the prothrombin. Then prothrombin will be able to go ahead and activate factor 1, which is the fibrinogen, and also factor 13. Yeah. So factor 10 is part of the intrinsic pathway. Both are the common pathway. Yeah. So a defect in factor 10 will show up in both the intrinsic and extrinsic pathway, in that both of them, none of it will be able to be able to get to the main goal of coagulation, which is formation of the fibrin plug. So without factor 10, you will not have a coagulation or fibrin plug formation in case of both the pathways. You can go on. Right. A lymph differs from blood in having, all right. We know that blood also has immunoglobulins, and lymph has immunoglobulins. To say lymph has no plasma, and you know that plasma is a general term for everything, so that won't be able to accommodate it. You know that lymph, a major role of lymph is is you can think about it in when you're having a lymphadenopathy, what's happening in your body. It's a good sign, especially if it's painful. It's a good sign that you're having an infection. Yeah. So lymph and the lymphatic system is really important in fighting infections and all that. And hence, you know that the T cells, the B cells are all going to be circulating using the lymph. Yeah. So when you talk about the lymph it has more white blood cells, and the lymph has no red blood cells. Yeah. So that's the correct answer. Lymph will have more white blood cells, but it will lack it will lack the red blood cells. Right. So factor vitamin K dependent factors. We talk about that these factors have different names. We've talked about surface activators, surface dependent factors like factor 12 and factor 11. Yeah. So here is vitamin K dependent factors. Yeah. So here we can't see the normal factors that we normally have. Anyone can tell me which are the normal factors that we know? Which factors are vitamin K dependent? Right. So 2, 7. Right. So the correct way is going to be 2, 7, 9, and 10. How I always remember it is just take 2 plus 7 will give you 9 and then 10. Yeah. 2 plus 7 is 9 and 10. Yeah. So those are the normal factors that are vitamin K dependent. 2, 7, 9, and 10. 2 plus 7 will give you 9, and then the next one is 10. Yeah. So those are the ones that we normally know. The 2, 7, 9, and 10. Here is these ones are going to not part of the coagulation, rather they're going to be part of the anticoagulation factors, which is protein C and protein S. Really important to know these factors, because if you want to relate it even with pharmacology, is that when you're taking warfarin, which is an antagonist of vitamin K, in the sense that you want um to be able not to form these factors, so that, for example, someone who's having thrombosis, or maybe um uh, uh these heart diseases that are caused by thrombosis and all that, if you want to antagonize that one, things like myocardial infarction, yeah. So if you want to antagonize that one, you give warfarin, yeah. And when you give warfarin, one of the adverse effects that it has is that there'll be a necrosis, a dermal necrosis at some point. And the explanation to that one is normally because you're giving warfarin in the sense that you want to stop, to be able to promote the anticoagulation. But part of the anticoagulation factors actually dependent on vitamin K. So you're giving warfarin at the same time you're bringing down the anticoagulation system at some point, which is protein C and S. Lucky for us, they're not the important anticoagulative factors. As we talked about in the last session, we talked about that the main one is going to be the antithrombin, yeah? So they're not going to be that um impactive for that case. We can go on. Right. So in an adult, when the red blood cell survival is reduced to 20 days, the result is, last time we mentioned what the red blood cell lifespan is. Anyone can remind us approximately how many days? 120. Yeah, we said 120 last time. So if you're reducing your days by 20, now you're having 100 days. And that's the basic definition of things like hemolysis. Yeah. Hemolysis is that you have red blood cells, and what is happening is not a defect in production of red blood cells. You have them, but they're being destroyed. Yeah. The lifespan is now being reduced. That's the basic definition of hemolysis. Is reducing the lifespan of these red blood cells. So in that case, what are you going to have? An anemia, since you're dealing with red blood cells. Leukopenia is going to be white blood cells. Leukocytosis is high red white blood cells. Thrombocytopenia, and then polycythemia is increase in red blood cells, which can't be the case. So the correct answer is going to be anemia. Right. Hemophilia B, the Christmas disease, is due to the deficiency of uh, factor 9. Yeah, factor 9 is the Christmas factor. Yeah. Um, Hemophilia A is going to be, I think we all know this one is factor 8. But what about hemophilia C? Who can tell us hemophilia C, what factor is going to be deficient? Anyone? Hemophilia C. Yeah, factor 11. Yeah. So hemophilia A is factor 8. Hemophilia B is factor 9. Hemophilia C is factor 11. Yeah. Those are the three types of hemophilias that one can have. You can go on. All right. The condition that shows with prolonged both activated prothrombin time and bleeding time is, this is not just an MCQ question. It comes in essay and really, really importantly comes in the sports. Yeah. So what condition are you going to have in? You're going to be prolonged prothrombin time and bleeding time. You're going to have a problem in von Willebrand. So it's going to be the von Willebrand disease. Yeah. How does this come about? Von Willebrand, von Willebrand is a factor, right? So von Willebrand is a factor that um is important, number one, in platelet aggregation. Yeah. So when you're having and you talk about the functions of, how coagulation starts. The first thing we talked about last time is the primary hemostasis. So for primary hemostasis to happen is that you have a damage to the endothelium. Yeah. So in the case when you're having a damage to the endothelium, what happens is that there'll be expression of the von Willebrand factor. And this one will be able to help activation of platelets, and then platelets are going to activate and then aggregate and flow and form the platelet, platelet aggregation. Yeah. So von Willebrand number one is really important in platelet activation. Number two, von Willebrand factor is really important in the preservance of the factor 8. And we talked about factor 8 is one of the factors in the intrinsic pathway. So von Willebrand is going to have an effect in the intrinsic pathway and an effect in platelets. And as last time we discussed, bleeding time, and we gave examples, has an important effect or is going to be able to help us measure the primary hemostasis, which is the blood vessels and the platelets. Yeah. So if you have a defect in platelets, your bleeding time is going to increase. If you have a defect in your blood vessels, your bleeding time is going to increase. And hence, in von Willebrand disease, we're having a defect in platelet activation, and hence, a bleeding time is increased. We also mentioned last time that prothrombin time is going to be a measure of the intrinsic pathway. I mean, no prothrombin time, the activated prothrombin time. It's the APTT. Is going to be a measure of the intrinsic pathway. Yeah. And hence, if you're able to have an effect, something that is affecting the intrinsic pathway, which we talked about, von Willebrand is going to affect factor 8, and factor 8 is in the intrinsic pathway, you're going to have an increase in those levels. And so the answer of choice here is going to be the von Willebrand's disease. All right, we'll start this other paper because of time. We have still have a lot of time. So question one, hematological manifestations of a thrombotic microangiopathy is going to be. So the correct answer is going to be the microangiopathic hemolytic anemia. So in macroangiopathic hemolytic anemia, you're going to have a type of mechanical hemolysis that will result in not spherocytes, but rather schistocytes to be produced. Schistocytes are fragments of red blood cells, so they'll come in different shapes, like a helmet shape that is going to be called a helmet cell. Yeah. So who can tell us what examples of microangiopathic hemolytic anemia? In what conditions do we refer it that MAHA is actually taking place? All right. So HUS, hemolytic uremic syndrome, a TTP, thrombotic thrombocytopenic purpura. Actually, ITP is not that. Yeah. Instead of ITP is going to be a TTP. Yeah. So TTP, that's right, correct. HUS, TTP, the HELP syndrome, that's correct. This one common, everyone should know. DIC. Yeah. So DIC is going to also to be part of them. Yeah. So DIC, HUS, TTP, and also the HELP syndrome. We can continue. All right. We're being told an anemic patient is found to have hypochromic microcytic red cells. Additional tests reveal that the serum iron levels, the total iron binding capacity, the transferrin saturation are all reduced, but a bone marrow reveals that iron is increased in the bone marrow. So what's the correct diagnosis? So number one, you're being given a picture that it's already a microcytic hypochromic. And we know that we have the three causes of a microcytic microchromic. One of them is iron deficiency. They go ahead and tell us that if you check in your serum, the ions are low. Your TIBC capacity is reduced as well. And the transferrin saturation is also reduced. However, really importantly, is that in this condition, you're having your iron stores, and one of the iron stores is the bone marrow. Others, we talk about macrophages in different tissues, like in the liver. The macrophages are going to be a good store of iron. So if they've given us an example, if you check out the stores of iron in the bone marrow, this condition presents that you have high levels of iron in your stores, but you cannot use them. Your blood says that you're having a problem in iron, you're having an iron deficiency. So what's the problem? What's the cause? Definitely it can't be just any iron deficiency. Rather, we talk about an anemia of chronic disease. In cases of an anemia of chronic disease, there are several theories. One of them is that there's production. What your body tries to do it's a chronic disease. For example, you're having a bacterial infection such as a TB. What your body wants to have is that you want to be able to keep away iron, which is actually an important component or an important nutrient for bacteria to be able to develop, isn't it? And to be able to survive. So your body adapts itself to be able to stop that your blood cannot be able to have iron and have low iron levels so that it can be able to deal with this bacteria. Another theory is that you know that an anemia of chronic disease is that you're having a disease that's taking place, and a disease is translated that you're having an infection, an inflammation, and chronic inflammation. So in an inflammation, we know that there's production of these things called acute phase proteins. Examples are the CRP, yeah. So one of the acute phase proteins is actually hepcidin. And what hepcidin does is actually a regulator of iron in the sense that it stops iron stores from releasing iron. So in cases when you're having an anemia of chronic infection, you'll have iron present within the stores, but you cannot be able to utilize them because they are not able to get into blood. And that's the picture you're being given here. All right, question 21. Which of these is a typical of a delayed hemolytic uh, transfusion reaction? So a fall in hemoglobin days after transfusion with mild jaundice. So you know that, as the name suggests, is that we're having a delay in the hemolysis, and hemolysis transforms into jaundice. Yeah, so one of the signs of jaundice, one of the signs of hemolysis or hemolytic disease is that there is jaundice. The patient presents with jaundice. Hence, question A is really correct in the sense that, yeah, so you're having a fall of in hemoglobin, and that's anemia. days. Yeah. So if you're able to describe delayed and acute hemolytic reactions, the difference is a delayed takes place days, preferably, as the notes suggest, to 2 or 3 to 6 days there. Yeah. So in to 10 days. Yeah, 2 to 10 days there. It's happening, and hence this anemia is not just abrupt, and the jaundice is not abrupt. Rather, it takes place within days. For ABO compatibility, we know that ABO compatibility, and I think there's a question that comes next or later on, is that ABO compatibility presents as an acute. It's really um fast in because we already have antibodies. Yeah, we already have formed antibodies against these antigens. Yeah, so it presents very fast. However, for the delay type, what they do describe is that it's happening due to these other systems. Remember, when you describe your blood grouping systems, it's not just the ABO blood systems. We have the RESA system, we have the KID system, we have the Diego system, the Lewis system, and all these other systems of antigens that might be present within our red blood cells. Yeah. So ABO compatibility is not going to be presenting as delayed. It can be within 30 minutes. You've said that it happens within a time, isn't it? About the temperature, what at our 1 degree temperature change within 1 hour of commencing. So you can check out that the concept of being delayed is going to happen within days later on. Yeah. So the correct answer is going to be A, is that your hemoglobin, you're having anemia later on. Continue. Okay, von Willebrand's disease is characterized by abnormal platelet aggregation, when platelets are exposed to. Um, I want someone to answer this. I know, I think someone knows this answer, and we talked about it last time. Exactly, listosettin. Yeah. So last time we talked about, and I told you guys to be able to go ahead and check out some of the reagents that are going to be used for a certain cause. Yeah. And you've just described right now that von Willebrand is really important in the platelet activation and hence later on platelet aggregation. Yeah. So if you're not able to have in platelet aggregation, what ristosettin does is that it's there to be able to increase the expression of von Willebrand disease. So in case like you're doing a test, yeah, and we talked about this is a platelet function test, where you want to check out is your platelet, can they be able to aggregate well? Yeah. So what you want to do is that you're giving certain reagents, and we talked about which reagents are used. Yeah. We talked about ristosettin, we talked about ADP, other agents are arachidonic acid, adrenaline, and collagen. So these are used in platelet aggregation tests. But for ristosettin, what it does, it increases the expression of von Willebrand disease, and increasing disease, increases the expression of von Willebrand factor. And increasing that one, it helps in the process of platelet aggregation. Okay, so in this case, um, it's going to be characterized by abnormal platelet aggregation, and platelets are going to be exposed to ristosettin. Why is because giving ristosettin increasing the expression. And if you don't have it in case of von Willebrand's disease, there is no von Willebrand. What are you increasing its expression? So there'll be an abnormal platelet aggregation in that sense. Okay, the others are going to be ADP. So we talked about ristosettin, ADP, um, uh, arachidonic acid, collagen, and adrenaline. Right, we can continue. I'd request Rono to explain this. Ned, tafadhali.
Okay, I'll explain. A 5-year-old child had the following white blood cell counts: 10 times 10 power 9 per liter. Differential counts: neutrophils 30%, lymphocytes 65%, monocytes 5%. The best interpretation of the above is, here are the choices. So I'd like for the chat to try, first of all, and see your answers. So let me see the chat, what they're saying. C, lymphocytosis, 65% of lymphocytosis, okay. Neutropenia, so 30% neutropenia, and monocytopenia, 5%. Okay, there's someone else saying normal distribution. There's someone else saying lymphocytosis. Okay, so they're varying answers. It seems like an easy question, but someone else is saying D, lymphocytosis and neutropenia. Yes, so they're varying answers, and I'll explain. So for this, the catch is, look at the white blood cell count, which is 10 times 10 to the power 9. Now, if you were to do the absolute count of the exact differentials, for example, neutrophils are 30%. So ask yourself, what is 30% of 10 times 10 power 9? Which will be 3, isn't it? 30% of 10 is 3. 3 times 10 power 9. Lymphocytes, 65% of 10 times 10 power 9 will be, so 65% times 10 is 6.5, isn't it? 6.5 times 10 power 9. Then monocytes, 5% times 10 times 10 power 9 is 0.5 times 10 power 9. So the question is, with those values you have in mind, now work from there. What is the interpretation? So ignore the percentages, just do the absolute count. And as I've said, the neutrophils will be 3, lymphocytes 6.5, monocytes 0.5. Now in the chat, you can now say your answers. What would be the interpretation? Lymphocytosis. D. I don't know how you got neutropenia, because I saw the neutrophils are 3, and yesterday we said between 3 and 7. So it can't be D. I'm seeing people saying A. Yes. So lymphocytosis. So our interpretation is lymphocytosis. But now, this question, the correct answer actually should be lymphocytosis. That is the best interpretation. But now, this question, how the department marked, they marked with normal distribution. That's the answer they marked with. And trying to reason out with it, we had 2 theories. Number one, the normal WBC count is 4 to 11. And the WBC count here is 10 times 10 power 9, which if you ignore the differential counts, this is actually a normal distribution. It's between the ranges. So that was our first theory. And the second theory is this patient has neutrophils 3 times 10 power 9, isn't it? Yeah. Yes. So yeah, just use that reason. That's the reasoning we tried to come up with why they'd mark this question with normal distribution. So in case it comes, you pick normal distribution, but at the back of your mind, you know that the answer is lymphocytosis. Okay, so I think that's clear. Any question? Does the age of the child affect values? Does it? I don't know. You tell me. Does the age of the child affect the values? Yeah, so I hope you've understood how to do this. There's going to be another similar question like this. So the percentages can be confusing, but do the absolute count, okay? So in case it comes in the exam, the exact question, pick normal distribution, but at the back of the mind, you know it is lymphocytosis. Yeah.
So thanks. Right, so the serum total iron binding capacity is inversely proportional to the serum levels of, so TIBC is the total iron binding capacity, so of the transferrin, yeah? So what is it inversely proportional? In the sense that if it's high, then this one is low, and if it's low, then this one is going to be high. All right, iron, that's correct. So if you're having an iron deficiency, it's going to be an iron deficiency, iron is low. So serum iron is low and TIBC will be high. And if you're having high iron levels, iron is going to be high and TIBC is going to be low. Right.
So here, can you explain on the hemopexin? I'm seeing someone has asked.
I'm not sure about it. I think it's like haptoglobin. Wait, I don't want to say. I'm not sure. I'm not sure. I'll check out on that one and then we'll do it next time. Or if
Okay.
you know, right. The hereditary hemorrhagic telangiectasia will manifest in the following tests. Will manifest, meaning that if you do this test, you're going to be able to know that maybe this patient has a hereditary hemorrhagic telangiectasia. IV is common, extrinsic, intrinsic, and short pathways. So who would tell me? We've discussed about this a lot of times. Right. So for this, in the case of this one, what we're having, or the problem we're having in this case, is that we're having a blood vessel problem. And as I told you, that the blood vessel is part of the primary hemostatic system. Exactly. That's great. IVs. So the primary components of the primary hemostatic system are going to be mentioned, are going to be measured, or going to be tested by the blood, by the bleeding time. And here what they've just done is that instead of writing bleeding time, they've given you the examples, IVs or template, or the third one, the Dukes. So Dukes, IVs, templates, they've just given you examples here, but that's the correct one. It's the bleeding time. Because you're having a problem in your blood vessel, it's going to manifest in the bleeding time. All right. So a healthy infant has a blood type A negative, is born to a mother who has an O positive. This is a second pregnancy. The baby develops jaundice and anemia. The infant's direct antiglobulin, which is the Coombs test, is for IgG positive. Yeah. So what is the most likely causative antibodies? Yeah? So in this case, the child is an A negative. Yeah, meaning that the child has a anti-A. I mean, the child has an antigens A, but they lack the rhesus antigens. The mother is O positive, meaning that the mother has lacks antigen A and B, and it contains the rhesus antigen. Hence, if you have an antigen, that means you're lacking the antibody. We go to the mother. The mother has a rhesus antigen, hence they lack the antibody. So whatever is happening in this case is not because of a rhesus antigen, or antibodies. Why? Because the mother lacks the rhesus antibody, because the mother has the antigen. So always know, if you have an antigen, you lack the antibody. If you lack the antigen, you have the antibodies, because you can't have an antibody against what you have yourself. You can't have an antibody against yourself. Yeah. So the mother lacks antigen A and B. Yeah. And hence she'll automatically have antibodies A and B. So anti-A and B. Yeah. And this baby contains antigen A, but lacks the rhesus antigen. Yeah. So what's happening within the baby is that the antibodies which the mother has, which, as we have agreed, is anti-A and B. Why? Is because the mother is an O blood group, meaning that they lack antigen A and B, and hence they have antibodies against A and B. When they cross the placenta, they'll interact with the baby, which has antigen A, and hence the anti-A and anti-A B. And since you have these antibodies, the antibody part of antibody A is going to be attacking the antigens or antigen A on the red blood cells of the baby. So what's the most likely causative antibody is going to be anti-A and anti-B, because these are the antibodies that the mother contains, and these are the antibodies that will cross the placenta to go and have an effect on the baby, because the baby has antigen A. Hopefully that's clear. Right. So which fresh frozen plasma can be safely transfused to a patient whose blood group is unknown in an emergency situation? Yeah. So in case of in an emergency, right, someone is asking what will happen if the baby was O negative. There'll be no problem. Why? Because there'll be the antibodies that are crossing. It's just the only there is anti-A and anti-B. So when they cross, they'll have no antigen to attack. Yeah. So the antibodies that are crossing will not have anything to attack. But since our baby, in our case, the baby has antigen A. Yeah. So the antibodies that are crossing, they're against antigen A and antigen B. And since the baby has antigen A, those antibodies are going to attack the baby, and hence the presentation that the child has. Right. Back to a question. So which fresh frozen plasma, yeah, can be safely transfused to a patient whose blood group is going to be unknown in case of an institution. So what you're dealing with here is we are dealing with a plasma. Yeah. And as you all know, the blood component contains the hematocrit part that has the red blood cells, and then you have that buffy coat that has the platelets and red blood cells. And then lastly, we have the plasma. So when you discuss what plasma is the part that contains everything else excluding excluding the cells. Yeah. So importantly to know in our case is that the plasma will be able to contain antibodies. Yeah. So what they're trying to tell us is that you have someone you don't know who's Nini, which is the best plasma to use. So you want to have the plasma that has no antibody. Yeah. Follow. You can tell me to repeat if there's no problem. So you want to find the plasma that has no antibodies. Get that right. Plasma will not have any cells. So you don't want to know which antigen. They just want to know which antibodies are present within this patient. Yeah. So we start with O negative. For O negative, this patient, yeah, has no antigen A or no antigen B. Just like the mother we talked about was O. But the problem is the patient is going to have antibodies because she doesn't have those antigens, or the patient doesn't have that, or the person doesn't have those antigens. So they'll be able to have antibodies against the antigens that they don't have. So an O negative person is going to have antibodies, anti-A, anti-B, and also anti-D because they don't even have the rhesus. Yeah. So as we said, if you have the antigens, you lack the antibodies. If you lack the antibodies, you have the antigens. Yeah. All right. So the next person is an A positive. Yeah. So an A positive is going to have um uh, an A positive has antigen A, but will not have antigen B, and hence they are going to have an antibody against B. So in case our patient who's in the emergency is a person who has a B, you have a problem. So you don't want to use that one. You go to the other one, O positive. So for O positive is like the mother we talked about. They have antibodies against A and B, but they have the rhesus, yeah. So they'll be able if they're positive, rhesus positive, they lack the antibodies. Yeah. So this patient, we are not giving them because they lack they have antibodies against A and B since they like it. We go to D. D, they have antigens A and B. And we said if you have an antigen, you lack the antibodies. So you're not going to have any antibodies against A and B. You get that? So you're not going to have any antibodies against A and B. However, the person is negative. B is negative. So it depends. Have they ever come across a rhesus to be able to produce the antigens? Is the person a mother? Has the mother given birth to children that have positive and all that? Comes back to the problem. E, the person has all the antigens. They have A, they have B, and they even have the rhesus. And if they have all these antigens, they lack the antibodies. Yeah. So you want to have antibodies against antibodies against there'll be no antibodies. So giving this patient this plasma will not be able to have any problem. Yeah. So for me, the correct answer will be E. Right. So a 45-year-old female patient with fever had the following counts. Hemoglobin is 13 within normal, range. White blood cell is going to be really high, 20. And then we have differentials, neutrophils are 90. So if you, as we have been told how to calculate the different values, if you do 90% of 20 times 10, you're going to have 8, is it 18? Something, yeah, 18 there. Lymphocytes is 10%, platelets is within the normal values. So really what they want to know here, right? Someone is referring me to the next question. Let me finish this, we'll go back. So what we have a problem here is really the white blood cells. The white blood cells is where we're having a different is there is a lymphocytosis, yeah, and the lymphocytosis that's happening here is specifically for neutrophils, yeah. So the falling blood film appearance will be the least likely, yeah. So in lymphocytosis, when you're having high levels, we can be able to think about it in two ways. Yeah. If it's really, really extreme, is that we are dealing with either two things. It's either the patient is presenting with a sort of a leukemia, or patient is presenting with a leukemoid reaction. A leukemoid reaction is when you're having, they describe it as a benign or a non-malignant increase in the white blood cells. Yeah, I'll refer you to go and check out what conditions would give you such things. But basically, infections is a good example when you're having high levels of white blood cells. So when you're having a leukemoid reaction, in case of this, what we're having here is that you're going to have characteristic things that you'll be able to see in your peripheral blood cell. One of it is going to have a toxic granulation. So toxic granulations is, the granules that are seen with, within neutrophils that are normally described as fine granules. So what you'll have is that there'll be too much granulations. It's toxic, meaning it's really, really too much. Number two is that you're going to have a neutrophil or a left shift, meaning that you'll be able to see these earlier forms of neutrophils like the band form or the metamyelocytes within your peripheral blood field. Another thing is characteristic of leukemoid reaction is what is referred to as Dole's body, which I'll refer you to go and check out how it looks in a film. Number four, you're going to have vacuolations. And the last one you're going to have, really importantly, is the lab score. So the lab score, the leukemoid, the leukocyte alkaline phosphatase score, is really important to be able to differentiate for you what a leukemia and what a leukemoid reaction is. Like basically, that's a really, really important differentiation to be able to clearly know if you're dealing with a leukemoid reaction or a leukemia. In case of a leukemoid reaction, your lab score is going to be high. In case of a leukemia, your lab score is going to be really low. So that's a really important differentiation. Come back to our question here, the least likely. We all know that oral rods is a key feature for what do we call them? Acute myeloblastic leukemia. Yeah. So the myeloblast is characteristic for oral rods in the blood cells. So that will be the most correct answer. It won't be there and present within this type of anemia. So we talked about how we are having normal levels of red blood cells. So the red blood cells are normal lymphocytes, the left shift and toxic granulation. All right, we can go to the next to the previous question. Annette, you can explain.
I think you had explained. Well, I'm seeing someone is asking, which frozen plasma can be safely transferred to a patient whose blood group is unknown? in an emergency situation? As you said, the fresh frozen plasma contains the antibodies, isn't it? Yes, so you want to give someone blood that has no antibodies to react with their antigens, antigens on the surface of the red blood cells. So we have to give AB. That's the first thing. You can't give O because O has A antibody A and B, but AB has no anti-A or anti-B. And then because it's an emergency situation, and to avoid giving rhesus, because imagine if you give rhesus positive and the person is, you give the person rhesus positive blood and the person is rhesus negative, and maybe they had been exposed to rhesus and they already have antibodies formed against it, there'd be an agglutination there. So I think the best answer should be AB negative. So where you have no anti-A or anti-B and you don't have the rhesus. I think, Adnan, you can continue.
Should we stop there, Ama? Continue next time.
I think